Hello and welcome to Triage, timely conversations for healthcare professionals, a podcast created and produced by K&L Gates. Each episode is designed to highlight important developments in health law and analyze the impact on our clients and friends of the firm. We hope you enjoy this podcast.
Hello, everyone. Welcome to this week's Triage. This week, I have with me Rebecca Schaefer, who I'll let introduce herself in a moment. But our topic for the week is a question we pretty regularly get from clients related to the intersection of clinical research and quality research, which can often create some blurred lines. And so we've invited Rebecca here today to help us clarify those otherwise blurred lines. So with that, Rebecca, let me let you introduce yourself.
Thanks, Rich, for having me today. I'm happy to be here. I'm Rebecca Schaefer, a partner in the RTP office, and my practice focuses on healthcare and research, regulatory, and transactional matters. And in that space, do a fair bit of support of clients' clinical research efforts and related HIPAA and common rule regulatory questions that might arise.
Thanks, Rebecca. And again, thanks for being here on this important topic. So let me let you sort of set the question up, because again, this is a question we get pretty regularly. So why don't you kind of lay out when does this become an issue? When does it typically come up for clients that they give us a call about this one?
So I think as everyone's continuing the march towards value-based care, value-based reimbursement models, and continuing their evolution of population health activities, it's giving rise to an advent of, more and more availability of integrated clinical records. So imagine a repository that's got both medical record and claims data matched, and that could be amassed across an accountable care organization or a clinically integrated network or maybe a health information exchange, folks that are coming together to advance, quality or quality improvement, cost reduction, pop health type initiatives. And obviously, folks are appreciating the treasure trove represented by these data repositories and the power that are present in them if you could leverage them to advance different quality assessment, quality improvement, or research initiatives. And so the questions are often coming up as people are looking to make secondary uses of those integrated clinical records that are already being compiled as a result of these population health initiatives.
Yeah, it makes complete sense. And this is, something we began to see with the rise of value-based care, but it is obviously, it seems now as well, the ability to manipulate and really work with that data has advanced so much in the last 5 years. It makes sense that, this is going to be a continuing topic. So, Rebecca, maybe it would be helpful for everyone as a starting point to just kind of fundamentally, what is the distinction between a research purpose versus a quality initiative that kind of drives how to assess all of these questions?
Sure, and it's a great question, and really the answer to which is going to determine what regulatory tripwires you're hitting and then what obligations or compliance steps follow. So I think, in my view, it fundamentally boils down to QA/QI is really about studying performance relative to a defined measure. So just imagine participation in a quality payment program, whether it's a CMMI program or otherwise. You're reporting on different quality metrics, and maybe you've got corollary assessments that are, designed around those data you're already collecting for those purposes, but you're really assessing, or the provider is really assessing their performance relative to those defined metrics. Whereas research, by contrast, is about seeking to understand why a particular health outcome or particular, type of performance is occurring. Really, what are the reasons, whether they're, different comorbidities or social determinants of health, any myriad number of variables that could be driving a particular health outcome. I think a research question is fundamentally seeking to understand why that's occurring and maybe also with an eye towards defining clinically valid metrics or measures for the future.
The distinction makes sense, although I do imagine that with that framework, of course, folks working in the quality space pretty often are going to drift into wanting to understand the why of, where their performance is improving or not improving and how to kind of move those levers. And I think that's why we get a lot of questions in this space. Again, just kind of from a level setting perspective, can you just make sure everybody's got top of mind what are the regulatory regimes that you're caring about when folks come with this question of what am I really doing? And if it is research, what does that mean for compliance?
Sure. So this audience will be well familiar with HIPAA, of course. I mean, the two primary regulatory regimes we're talking about today are HIPAA and the Common Rule, which is the federal policy for the protection of human subjects. But just with respect to HIPAA, again, a well understood delineation of what is permissible when an activity is QA/QI. So providers can use PHI for their own healthcare operations, where that's a QA/QI activity. They can also disclose it to another covered entity if the receiving party has a common treating relationship with the patient. And if there are parties that are part of an organized healthcare arrangement, which may be common in an ACO or SIN context, if they're participating in an OCA, they can also share PHI for QA/QI purposes of the OCA, even where there may not be a common treating relationship. The Common Rule, again, the federal policy for the protection of human subjects, which is found at 45 CFR Part 46, is a regulatory regime, some may be less familiar with. And that is what sets out, requirements based on the profile. It first defines research and then what reviews are needed to make sure that there's ethical treatment of human subjects and that they're adequately protected through the study protocol, and that those reviews happen under an institutional review board or IRB. So again, that's why it's important in some ways, depending on the nature of the activity, to understand if you're in a QA/QI lane or you're in a research lane, because it's going to drive what reviews may be required for the particular study or investigation in question.
Great. And so then going to the kind of the crux of the question, as you're helping clients to decide, does something, kind of hit that research tripwire where it may need to go to the IRB? What are the factors that in your view are most important?
Yeah. First, I'll just start by sharing that at least helpfully, HIPAA and the Common Rule have the same fundamental definition of research. They both address research in different ways, but they do have a common definition, and it's a two-prong, which is research is a systematic investigation that includes research development, testing, and evaluation. And then the second prong is that it's designed to develop or contribute to generalizable knowledge. So where the regulatory definitions diverge, however, is that HIPAA classifies an activity as healthcare operations and therefore not research if obtaining generalizable knowledge is not the primary purpose of the activity. So if the primary purpose really is healthcare operations, QA/QI, we need to improve the workflow in this clinic, we need to get this particular clinical measure better controlled for this cohort of our patient population, then your primary purpose really is not contributing to generalizable knowledge through publication, for example. The Common Rule, by contrast, indicates that any activity may be considered research if one purpose or any purpose is obtaining generalizable knowledge. So this feeds into the factors, back to your question. What are some factors that folks can look to as they're trying to decide? And some of this is subjective. Is whether the investigation, so to speak, whether the study is purely clinical or for administrative purposes. Maybe it's limited to understanding, analyzing, and perhaps improving operational efficiency and effectiveness. Certainly if it's designed to address payment measurements or payment reporting requirements, those tend to weigh in favor of determining that it's not research. On the other hand, if the purpose, this is back to sort of the fundamental notion I started with about what is research fundamentally, it's trying to understand the reasons behind particular health outcomes and to study those. And a factor that folks tend to use as a bright line is whether or not the results will be published, because certainly that will be indicative of contributing to generalizable knowledge. So those are, some of the factors.
That's very helpful. And I assume then from a bottom line perspective, the concern with hitting that research bucket is now you really do enter an entirely different regulatory regime that, for example, a typical ACO may not even be set up to manage compliance with. And are there some kind of key areas of, research compliance that, particularly for folks that come to this podcast thinking more from the QA/QI side, that they ought to just be aware of?
Yeah, fair. So I think big picture, If the research tripwire is hit, then as you've mentioned, right, I've got potentially an IRB review process. If it's non-exempt research, that will typically involve a consenting process. It's possible in the context of a retrospective data review that the requirement to obtain consent and HIPAA authorization may be waived by the IRB if it's impractical to obtain. There are other avenues to get there, de-identifying the data in order to then conduct the research study or investigate the research question, though, query whether you're able to meaningfully answer the question without the availability of identifiers and mapping or integrating those data with other data sets. But yeah, big picture, we're having to think about writing a protocol for the IRB to approve from an ethics perspective and potentially contending with consent processes with the individuals that are going to be the subject of the data set.
Yeah, and again, I think what we find, particularly with our clients that are operating ACOs and SINs, and this sort of really a world unknown to them, which is why important to kind of have those guardrails in place to really essentially make sure you don't trip that wire.
It's probably also helpful to point out that with changes to the common rule that became effective in 2019, there is a new HIPAA exemption to the common rule, which is helpful to understand. And we actually have advised clients on this space. So let's imagine that the primary purpose of the reason a particular set of data were collected was a QA/QI purpose, and a provider or even a group of providers through an ACO or SIN were just seeing how they performed relative to a clinical protocol that they were rolling out throughout the organization or the group of providers. And at the end of that, the providers realized, hey, we really found that this worked, and we think it would be great to share that with the broader provider community so that everybody can, help their diabetes patients with the benefit of this particular approach or this particular clinical protocol. So, going back to what some people use as a bright line, whether there's going to be publication, I think it may suggest that under the common rule, now we've got any purpose is potentially contributing to generalizable knowledge. The common rule might view that as research, whereas HIPAA did not because it wasn't the primary purpose at the time the data were collected. There's an exemption under the common rule as recently amended. But it is the HIPAA exemption to the common rule, which basically says that, notwithstanding that the common rule would define this as research and it might otherwise be subject to IRB and consent processes, if you performed it correctly under HIPAA, in other words, you were in your lanes to do a QA/QI project as healthcare ops, then this secondary research question is exempt from IRB review. So I just think that's a helpful note for a little space where some of these questions may arise and a little flexibility that's available to providers.
Yeah, that's incredibly helpful. And I appreciate walking through that last nuance.
Thanks, Rich. Yeah, and so just as a final point, I'm just flagging that there's a host of ancillary considerations that we haven't had time to cover in this triage episode, but that may yet be relevant for folks to consider. For example, whether the data involved may be subject to special protections, but perhaps they may involve substance use disorder treatment records protected under Part 2. There could be terms in the participation agreements that providers have to join their SIN or ACO that may impose limitations on data use or data sharing. And again, time doesn't permit covering all those different regulatory and contractual considerations, but just to flag that those should be among the checklist people are running as they're determining the uses they want to make of integrated clinical records and answering these types of questions.
Very helpful. Thanks. Well, I'm sensitive to time in terms of the length of our triage, but we do really appreciate you coming in, Rebecca, and walking us through this one, which is a pretty common question that we receive pretty regularly. So certainly helpful for folks to have this context. And with that, we will wrap up our triage and look forward to next week's triage.
Thanks so much, Rich, for having me. It's been a pleasure to be here.
Thanks again for listening to Triage, timely conversations for healthcare professionals. New episodes are available for download through Apple Podcasts, Google Podcasts, and Spotify. By subscribing to Triage, you will receive timely notifications for each new episode. Also, if you have any topics you would like to hear discussed on Triage, please don't hesitate to email triagesupport@klgates.com. We would love to hear from you.